Thank you. Thanks for the opportunity to come to the Society to present this late-breaking abstract. Here are my disclosures. So for everybody's review, Polycythemia vera is a relatively common myeloproliferative neoplasm characterized by excessive production of red blood cells. It's a relatively common disorder. There's probably about between 100 and 150,000 patients in the United States, and probably an equal number of individuals in Europe. There's an elevated hematocrit as the hallmark of the disease, indicating overproduction of red blood cells. And this uncontrolled hematocrit is associated with higher rates of death from cardiovascular causes or thrombotic events. It's been well shown by several studies that maintaining the hematocrit below 45% is critical versus, as shown by NCCN guidelines and also ENL guidelines, to decrease the risk of thrombotic events and cardiovascular events. The current standard of care does not do an effective job at maintaining hematocrits less than 45% in the majority of patients. So hepcidin is a peptide hormone that is made in the liver and is the body's main regulator of iron homeostasis, controls the availability of iron for formation of red blood cells by marrow erythroid cells. So this is somewhat of a paradigm shift. We're trying to use a hormone that's made by the liver to control excessive red blood cell production from a hematologic malignancy, polycythemia vera. So Rusfertide is a novel hepcidin mimetic that is designed to maintain iron homeostasis and normalize red blood cell production. And this hepcidin mimetic leads to degradation of ferroportin, which is an exporter of iron, and therefore traps iron in tissue macrophages and prevents the absorption of iron from the intestinal gut. So the study that we're going to talk about is the revised phase 2 study. All patients prior to the first Rusfertide dose were phlebotomized to hematocrits less than 45% to standardize the baseline hematocrit. So as you look at this concept, there are 3 parts of this study. One is a phase 1 dose-finding study where we essentially used in 70 patients, dose escalated these patients during weeks 1 to 16 to find the effective dose. And then from weeks 17 to 28, there's an efficacy evaluation phase. And what I'm going to discuss today is the part 2 blinded randomized withdrawal. So we had these patients who were either treated with phlebotomy alone or with myelosuppressive agents, and they were randomized equally to either phlebotomy or to continued respertide therapy. And at the end of this blinded withdrawal phase, these patients then had the opportunity, if they desired, to proceed on to an open label extension phase. The key endpoints obviously are safety, number and rate of phlebotomies compared to historic controls, and in part 2, which I'm going to discuss today, which is really the endpoint of the study, the proportion of responders that maintain hematocrit less than 45, reduction in the rate of phlebotomy, and patient outcomes as reported by a standard quality of life measure called the MPN-SEF Total Symptom Score. So here's the meat of the story. Rusfertide met the primary endpoint in this part 2 blinded randomized withdrawal period from weeks 21 to 41. 69.2%, 18 out of 26, were responders or non-responders per protocol. So these 69.2%, you can see in the diagram, is statistically significant with several zeros before the p-values compared to the placebo group. Now, 3 of these 69.2% patients actually filled the requirement for requiring additional phlebotomies. There were 5 patients who discontinued per patient or investigator discretion. Many of these patients there was an FDA hold on this trial due to concerns in a mouse model that had a predisposition to develop skin lesions that this drug might lead to increased incidence of skin lesions and possibly hematologic malignancies. When that was resolved, many of the patients who had discontinued their treatment due to the hold decided to proceed on to part 3. So that's why there's those 5 patients dropped out. All 8 non-responders continued in part 3 of the open label extension study. So 92.3%, 24 out of the 26 in the rusfertide arm, did not receive phlebotomy in part 2, the 12-week randomization part of the study. And here's a pictorial representation of this really paradigm-shifting treatment for patients with polycythemia vera. Here you can see the eligibility for responders in the control arm and in the rusfertide arm. Obviously, the rusfertide arm is the upper orange arm. Absence of phlebotomy eligibility and hematocrits less than 45%. And this randomized arm basically provides a unique opportunity for one to see the therapeutic efficacy of this novel approach. So in conclusion, rusfertide is a first-in-class hepcidin mimetic that selectively targets uncontrolled erythrocytosis. Again, we're using a recombinant form of a protein made in the liver to treat a hematologic malignancy. The REVIVE study demonstrated a significantly higher efficacy with rusfertide compared to placebo in subjects with polycythemia vera. Importantly, the study met the efficacy endpoints, which is the proportion of responders, absence of phlebotomy eligibility, and hematocrit control. Dr. Kremenskaya, during the late-breaking abstracts, will show that there's also dramatic improvement in PV symptoms, especially fatigue, and most notably, improvement in concentration, which patients often refer to as mental fogginess, pruritus, and also inactivity. Rusfertide was well tolerated. There were adverse events were generally grade 1 or 2. The most common adverse events were skin reactions, and there were no grade 4 or 5 adverse events. The current standard of care in PV does not provide consistent maintenance of the hematocrit greater than 45%. Usually we see these patients periodically, and they frequently require supplemental phlebotomy, therefore increasing the risk of thrombotic events. Rusfertide therapy provides an opportunity to chronically maintain the hematocrit less than 45% with the hope of reducing thrombotic events. And this drug is currently being investigated in an ongoing placebo-controlled verified phase 3 trial. I'd like to thank you for your attention, and again, thank you for the invitation to present at this news conference. Thanks.